So yeah, so what I'm going to talk about in next 15 minutes or so is we will start with why do we need insulin at all, right? So we need to understand, because if you're putting somebody on insulin and then we want them to be on insulin for a really, really long time, somebody suffering from diabetes, then we need to know uh, why do we need insulin. Second thing is first part of my talk is how to initiate insulin in people with type 2 diabetes, and then how to titrate that insulin in people with type 2 diabetes. So I think if all of us know this slide by and large, but what I just want to emphasize here is that we need to understand this, that whatever food we eat, once it gets digested, it goes to our blood, and the glucose that's there in our blood is not really needed in blood. It's needed in our muscles, it's needed in our fat tissue, and it is needed in our liver. And in all these three issues, the way it works in our body is that it cannot enter into any of these cells unless we have insulin. So the flow that happens in the body is that once the glucose enters into bloodstream, it goes to pancreas also, and then the insulin is released in a dose dependent manner. So the more the glucose, the more insulin is secreted, and then in these insulin molecules work as a key. So practically they come to each insulin sensitive cell, which in this case would be muscle, fat, or liver, and will open the door for this glucose to go in, right? So now the major difference in the major problem in type 1 diabetes is that there is no insulin that is being produced. So what happens is, now imagine you've got an original lock and you've got no key to it. So you really can't do anything about it. There is no way that you can modify that mechanism. You would have to get that key from outside. So in type 1 diabetes, insulin therapy is life saving. It is essential. No, people with type 1 diabetes can't even survive for 24 48 hours without insulin. So insulin is the only answer to the type 1 diabetes now. But starting and titrating insulin therapy in type 1 diabetes is a huge topic. So we're not going to talk about type 1 diabetes at all in rest of the time. We're going to talk about much more commoner type 2 diabetes that we go on. So what happens in type 2 diabetes is that the insulin is being produced. So we have the key. We have the original key with us and we have our original lock with us. Now somehow they are not fitting together. So what we can do in a lot of the times with type 2 diabetes after diagnosis is that we can modify action of either the lock or the key, and we can somehow make them fit together. Sometimes we apply a little more force, sometimes we just modify their action. So eventually we are able to open that lock and we are able to make this blood glucose go into muscle glucose. Now the ways we modify these action is the way the drugs for type 2 diabetes work. Now what we have to understand here is that if there is no key, then those medicines which are for modifying this action of key will not work. So as type 2 diabetes progresses, the body's store of insulin also go down. So eventually somebody with type 2 diabetes, say 15 years down the line, almost 50% of people with type 2 diabetes will not have adequate key in their body that even after modifying its action, we can maintain blood glucose. So almost 50% of people with type 1 diabetes after 15 years of their diabetes duration will eventually require these key to be given from outside, like we are doing it in children with type 1 diabetes. So which essentially kind of uh, uh, tells us that now I ask myself, while I can manage type 2 diabetes with drugs, why do I need insulin in type 2 diabetes? So one would be if there is a decreased secretion that we talked with the time. So that's an absolute deficiency. Like there is nothing that it can be done about it. Now that there can be a second situation where it's a relative deficiency. So my body is able to produce enough insulin, I can manage my day-to-day operations. But if there is an additional stress for that particular condition, I have no insulin reserve so that I can dive into it and get more insulin for myself. So that's the time when I may need insulin for for some transient time, like if I have infection, if I say have stroke, if I have got heart problem transiently, so then I may need this insulin transiently from outside. But if I have an absolute deficiency, then I will need insulin for a very for rest of my life. So that's how I like to divide them. So need for insulin in type 2 diabetes, I say, is by choice or by compulsion. By compulsion is that if my beta cell mass is no longer there, if I've got other contraindications to other OHAs like renal failure or hepatic failure, I really can't do anything about it because those drugs cannot be used anymore. So I would use insulin. So this is by compulsion. So now we need to understand this because this was one of the myths. So people will come to us and ask, कि, डॉक्टर साहब कब तक लेना पड़ेगा insulin? So we need to explain them this. So if we know that we have done everything else in terms of diet, exercise, and medications, whatever we can give, if we are still needing insulin because beta cell mass has gone down or any other complication, then the answer is lifelong. While for other conditions, we can choose. Like for example, pregnancy, drug of choice, because it's safe for fetus, so we use insulin. Few people also tend to use insulin for a very short time at diagnosis by choice because few people say that it helps in preserving beta cell mass in the long run. There is no definitive data to that, but few people like that. So by choice, we are doing that. And then we can stop it. We know that we can stop it after 3 months or so, even earlier than that. And then as we talk if for intermittent illness, we can use insulin transiently and then it would eventually be stopped. So one side is where insulin would be started but will eventually be stopped. The other side is where kind of once insulin started, it will continue. So this will help us answer patients' query in a very clear way for how long will it go. Now, what we also have to understand is that starting insulin in a clinical practice is a dreaded question that everybody asks themselves. So, but the biggest barrier is our own hesitation. As a physician, I can tell you if I'm convinced that this is the next best step for my patient, and if that means that I need to initiate insulin in them, then I don't need to hesitate. I need to prepare for it. I need to foresee for it. The way how I do it is if I eventually think in my mind, okay, this person may need insulin a year or 2 years down the line. So I start that discussion right now. I tell them, okay, this is the last step that we are doing. We may need insulin as a next step if so and so conditions are not met, or if we are not able to control diabetes with so and so efforts with drugs, with diet and exercise. So that kind of helps me preparing their mind. Of course, if somebody comes to the first time to you and actually needs insulin there then and there, so then you have to spend a little more time with them, try and explain them the way I told you is why they would need insulin to for their glycemic control and why it would be useful for them. Now, in the patient's mind, the myths are there because they feel it's end of line. So, what we need to tell them that it's a physiological need. Insulin is like any other drug. It's a physiological replacement that we are going to do. And eventually, what is more important is whether our diabetes is controlled or not. Few people keep on lingering it on and then associate, okay, my kidneys got problematic because I had a kidney problem because I was started on insulin. The thing here is most of the time what happens is that they've got uncontrolled diabetes. People keep on delaying insulin initiation for their glycemic control and eventually end up with complication. And then nobody wants to own up that responsibility, and then everything is put up on drugs, which in this case can be insulin. So we need to be clear in that communication. Then of course there is a fear of pain because we still call it as insulin injection. Idea is that what we all need to understand is that insulin in injection that we take by pen is absolutely pain free. And I can tell you with my own experience, the moment we entered AIMS for my training way back 10 15 years back, we were all made to take insulin injection on first day of our training just to demonstrate us that it is painless. And when we are kind of worrying about people getting pain because of insulin injection, that went away poof. So what we need to tell people, and I keep on telling them, is okay, start this, and then if you feel any pain, I am there for you to help as to how to get that away. But believe me, over thousands of patients, nobody has come back complaining of pain to me as yet. Now, let me take you for rest of your journey through for with a case scenario. Say 60 years old lady has diabetes for 16 years, has an HbA1c of 9.5%. Renal parameters are normal, but has got retinopathy, moderate NPDR in both eyes. Her current drugs includes maximum dose of all possible OHs that can be given. So, what do we feel? Should we start now? Is seems to be the perfect candidate for insulin initiation 15 years after diabetes and then HbA1c 9.5%. Should we ask ourselves anything else? Okay, let me give you another piece of information here. Now she comes that least HbA1c in last 10 years or so has been 8.2 percentage. In the 5 years has been 8.2 percentage. Now that makes me wonder, why would that happen? Because if physiologically insulin is needed at that stage, it was not needed 5 years or 7 years or 10 years back. So why did this patient did not control their HbA1c to 7%, 6.5%, that or whatever targets this individual patient have? In that would make me worried. That because that would tell me that perhaps what we are focusing more on is the drugs, and we've been escalating OHs all along, and now we are escalating to next level to insulin. While perhaps the most vital part of diabetes therapy is diet and exercise is not as controlled as it should be. In this case, I will double down on diet and exercise. I will ask them to do their self monitoring of blood glucose at home so that I can look at whether there is a variability. And that chart would also help me assess whether the variability is largely related to the drugs or largely related to the diet and exercise that that person is doing. And then I will make my plan as to whether I should actually initiate insulin in this. So the clinical data, HbA1c, does not give us all information whether I should start insulin on in a particular patient or not. If diet and exercise is not there, believe me, her record is not going to be better than what it has been in last so many years. Even if you put her on next level of drug, it may come down from 9.5 to 8.7, 8.8 or so for some time. But if you will see 1 or 2 years down the line, you will still come back to same dose of insulin that's there. So uh, now, okay, I will say that okay, everything is done and we have ensured diet and exercise is there. Uh, what kind of insulin do we put them on? So we can put them on basal insulin, we can put them on premix insulin, and we can put them on something called basal plus insulin. For once we start them on insulin, what we also want to do understand is what do we do with the OHs, the current drugs that are there, because there people would believe that now we are on insulin, the the OHs should go on in my mind. So what we need to understand is we need to decide whether we are adding this insulin as an add-on therapy or whether we are doing this insulin as a replacement therapy. Add-on therapy means that I have got small amount of insulin deficiency. OHs can manage, but I need some amount of insulin running in my body. And then whether the replacement therapy is like completely going on insulin, which would require us to be more than one times in a day on insulin, and then we can gradually reduce our OHs from the therapy. Okay, so now I want to decide whether what kind of insulin, what type of insulin do I need to give? If you would ask me, even then I need more data. Now I've changed little parameters, HbA1c is 8.4, and then what type of insulin regime should I give? Now what I need for that to be truly decided, again, I would need some amount of SMBG data from this patient at home. Now if this data is like this, my fasting is high, my post meals are high, my nighttime sugar values are high. What I need to do is I need to put them on a nice 24-hour insulin, which will bring everything down. So this is a perfect candidate to start somebody on a basal insulin therapy. Now the basal insulin, of course, we know is glargine, is dagludec. By and large, these are the two that we want largely. NPH we also use sometimes, especially in government and rural settings, that need to be given twice. But what we need to do is we need to start basal therapy in this case. We start on a very low dose, 0.1 to 2.2 unit, which comes out to almost to be 10 units or maybe start with 8 units, and then we kind of titrate this dose further once we start them on. So while we are on initiation, let me change this in same patient. If I have data not like this, but I have data like this, my relatively fasting values are lower, my pre-dinner values are relatively lower, but my pre-dinner values are high, but my post meal values are also. What do I do about it? If I give them a basal dose, everything will come down. So at a point, my fasting already is almost okay. I just need to go a little bit down, but then that will not solve my problem. If I'll give more dose look to lower my post meals and dinner values, I will end up having hypoglycemia in the night. So this kind of pattern is not good for basal therapy. Then we need to choose premix therapy in this case, and we can start them on a premix insulin, which can be given morning and evening. Again, starting them on 10 to 12 units in a day would be good idea. We give premix in two divided doses. We put them on a morning dose and an evening dose, divided by default two-third and one-third. And but depending on patient's blood glucose values, that ratio can change. Premix has basically a basal part and 30% is the rapid acting part. So that rapid acting part is going to take care of post meal values that are very high after breakfast. And then the basal part is going to take care of the dinner values. And then small dose given at dinner will take care of slightly high fasting values that are there. Right. In this case, what we also need to see is we also need to see what blood glucose values looks like after lunch and after dinner. So generally in these patients, we will end up telling them to do those values as well. Now, if I change this data even further, my only post meal values are high, but my breakfast and pre-dinner values are almost okay. In this case, the choices can vary a little more. First of all, again, I need to know whether my values are also high post lunch or post dinner. If my values are okay post lunch and post dinner, then maybe it's just my diet at breakfast which is making a difference. Lowering carb content at the breakfast time will solve my problem, and then I can modify it with diet. I really don't need insulin at all. Or if my lunch values are high and my post lunch values are high, maybe I can use small dose of premix. Or I can, if my all other values are okay, despite my diet modification, my post breakfast still stays high, I would go ahead and add one dose of rapid acting. And I can also try to change some other strategies. Like I can put them on small dose of, for example, if I'm on sulfonylureas, I can take those glimepiride and gliclazide off. I can put them on a basal insulin and titrate my fasting, and then I can put them on drugs which control my post meal values like repaglinide or netaglinide. So I can put them along with voglibos or a carbos, and then my post meal values can come down and I can be on one dose of insulin. So there are different strategies, different people. We can choose how to go about it. Now the last part is titrating dose, which is really simple. Starting is difficult, titrating is not that difficult. First advice is never hurry to titrate the dose. It is okay to err on the lower side. Hypoglycemia is absolutely not accepted. Our fasting target is 90 to 130 milligrams per deciliter. Increase dose by 2 units every 3rd to 4th day if our values are still more than target. Once any value hit that target, we stop escalation, and that's what it is needed. Sometimes an OHA adjustment would be required, which can be done. Adjusting premix is a little more complex. What you have to do is you have to increase by 2 units if your pre-fasting targets are same and pre-dinner values are still high. Would be good idea generally to depending upon how high the values is, we can kind of increase both dose simultaneously, or we can adjust one dose and then go with another. If these do not work, next level of escalation will be to go into multiple subcutaneous injection, basal first, and then you pre-meal rapid acting dose can be calculated based upon whatever our need at each meal is. So just to summarize, before initiating insulin, we need to really assess whether we actually need insulin. And based on SMBG, we choose what type of insulin is needed. We start with a very low dose, then we titrate to individualized targets. No, one target is not good for everybody, and we need to be slow about it. Let's avoid hypoglycemia. And I cannot overemphasize that insulin is not a substitute to diet and exercise. Thank you so much.